Hey, everybody. Welcome to Tea Talk. So it's Tuesday as usual, about 7. I noticed that my computer will count down and it will say that it's like 2 minutes, I think, behind. So my phone says it's like 7:02, but my computer says it's 7 o'clock. So and it looks like Facebook again is having problems through StreamYard. So if you know anybody that's joining through Facebook, they're going to have to jump over to another platform, either YouTube or LinkedIn. Again, I like YouTube for the visual. I think it is the best experience when you're taking a look. So if you're not on YouTube, I highly recommend it. And it's worth registering. Like if you don't have a YouTube account, it's free. But if you register, then you can like and subscribe to the channel. And you can also set a little reminder, because I know some people just tend to catch us on the rerun or the, watch after the fact. But the YouTube itself will give you like a little reminder when it's about to come on. So I'm going to actually just try to get rid of that little notification I'm getting there for Facebook. And so let's see who we have in here tonight. If you haven't already, please just let me know in the comment that you're here and where you're from. I know we're going to have a couple of our regulars in here. Oh, looks like Ricky's in the house from Las Vegas. Ooh, I like the little icons. We've got the slot machine, the dice, and then the little chess piece and the cards, the symbols for the cards. Cool. I love the Las Vegas experience. It's more than what everybody thinks. Everyone just always thinks of the Strip, which of course is cool too, because there's a lot of great architecture there and everything, aside from the gambling and the shows, but there's a lot to see. And then they also have a lot of like hiking, nature trails and such. So it's great. And there's a lot of coding and documentation conventions that happen out there at the hotels that gives those in the profession an opportunity or an excuse to travel to Vegas. And actually, it's funny, the first time I ever went to Vegas was for a Medicare convention that had to do with risk adjustment. And the great thing about CMS is they host a lot of things for free. So you can sign up and either go virtual or attend some that they have, like certain locations. So obviously many years ago, they didn't really have the virtual option too much. So you had to travel to wherever, but now more and more they're doing a lot of virtual stuff. So CMS is pretty good about that. Looks like we also have Chantilly. Hey, Chantilly. Yep, from right here in Florida. We know you. And Michelle, thank you so much for making it. I'm so excited you were able to join. That's great. And we've got Christy. Hey, Christy. Nice to see you again. And so this is part 2. Last week, we basically did an overview of evaluation and management and just sort of talked about that code section in general and the new rules and the differences between what used to go on with the 1995 and 1997 guidelines and how providers are and were documenting, and then how those guidelines have changed, and then trying to kind of understand where providers are coming from and helping the providers out that may be joining and listening to understand what's new with documentation, what you don't have to do anymore, what you should be focused on. And so this is going to be part 2 of that, where we're going to jump into the actual elements. And I have 2 documentation examples to show. We can kind of walk through and go from there. And then as usual, since it's tea talk, I usually share the tea that I'm drinking, but today's an exception. I went with coffee, and I don't know if it's kind of blurry. I love Starbucks, but I like their blonde roast. I think it's because it really works. So Dunkin' Donuts coffee is just like too sugary for me. It kind of hurts my stomach. There's all the sugar. And it doesn't really give me the same caffeine effect as Starbucks. So I really like Starbucks coffee, but I needed the extra coffee. We had a long weekend. We were dog sitting, and we have 2 cats and 2 sugar gliders at home anyway. So one of our cats loves to wake us up at the crack of dawn every day, just in general, regardless. It could be that she wants to go outside into the screen room, or she just wants to be pet, or she just wants to see you get up out of the bed. So, and then with the dog there too, it was just a lot of extra going on. So I needed a little bit more caffeine this evening. So, I'm going to go ahead and jump in. Just remember, guys, if you have any questions, just put your chat in and I will pull them up on the screen and we'll go from there. Oh, it looks like we've got Eileen joining from Florida. Hello, hello. Oh, Ricky. Okay, so today is sticky rice. I don't know how to say that. Pure tea? I don't know how to say that, but is that sweet? Would sticky rice tea be sweet? I'm sure it tastes like sticky rice. That's probably why they call it that, but just curious. So I'm going to do a little bit of screen share in between. And like I said, I've got, so sorry, I'm just laughing because I saw this comment come in. So you pronounce it pu'er, right? So it's sticky rice pu'er tea. That sounds awful. Okay. Anyway, so I'm going to do a little bit of screen share. We'll go back and forth. And if you guys have any questions about the cases or comments, please share. If you guys have anything to share, you can always email us at ttalk@stalkinghorsellc.com. So if you send an email to that address, we will get it, and then we will respond through another Tea Talk episode with your questions. So we've had actually some additional requests come in. I had mentioned before for transitional care management, I think nursing home visits, and there's one other one that depression screenings. And so we've been asked to kind of go over documentation requirements for those. Some providers had asked, they were a little bit concerned about whether they were meeting the mark and just wanting to make sure they knew what was required. So those are being added to the schedule. I've got the request in for the thumbnail to be created so we can go ahead and schedule those. So that they'll just be added on to the end of what we currently have. And again, remember, if you're not on YouTube, please join the herd. So like and subscribe. And you can follow us also on Instagram, Facebook, and LinkedIn. We're on all of those as well. And we do the code of the day. But the best way, again, to get a hold of us is through the ttalk@stalkinghorsellc.com. And then our website is stalkinghorsellc.com. And we have some different webinars and such up there as well. And so also, if you guys request this information that we go over today, so all the attachments that I'm going to share, well, most of the attachments that I'm going to share, I won't, I don't think I'll send over the examples, but I will post the table and the guidelines on our website. There's a spot on our website for Tea Talk specifically. So any documents that we share will go up there so that you can visit that website to download them and have them. So I put them in PDF format so you guys can see them. All right. So I'm going to go ahead and start sharing my screen. Okay, taking myself off here for a second. So this is the table that is used to go over and find the level of evaluation and management service or office visit. We're focusing on office visits right now because, as I mentioned before, that evaluation and management section of the CPT is huge. And so like the nursing care visits and transitional care management, all that stuff like belongs in that section. It's humongous. But we get a lot of requests to just go over the guidelines that are related to when a patient goes into the office, provider sees the patient there. So it's office and other outpatient services. So your 99202 through 99215 codes is what we're going to focus on. So that document here is the official document, except for the fact that we added this code section here where we put in the codes that we're going to discuss. So we've got the nurse visit up top, which is 99211, which doesn't require any leveling of the elements. But then we have 99202 and 12, 99203 and 13, 4 and 14, 5 and 15. So for those of you that are providers or are new to coding, because I know there's a few in here that are, we have the 202, anything with the 0 in front of it in these codes are new patient visits. And we did have a prior episode that talked about the new patient. So if you missed that live, you can go to the YouTube channel, click on the live section, and you could actually watch that video regarding new patients and the 3-year rule. But the 99202 to 03, 04, 05, those are new patients. And then the one with the 1 in front of them, so 12, 13, 14, and 15, those are for established patients. So I want to give you guys a little pro tip here. So something that I do, and as far as I know, our entire team does, and I may have mentioned this before, but I'm going to mention it again because it's worth it. We take the clear sleeve that you can buy from any of the supply stores, right? And it goes like in a notebook, and we slide in the table. So let me turn this around for you. So we slide in the table. So it makes it become almost laminated like. And then we keep these, our team keeps these next to us all the time. And even though I've been doing this for over 20 years, I don't like memorizing anything. And that's the truth of it. I have too much in there. Stuff starts to fall out. So I love having this in front of me. I reference it all the time, just in case, especially when I'm auditing or reviewing work for our team. But it's nice to have this in front of you and laminated like that. So in particular, for those that are new also, if you're just getting to know this table, and for the providers out there, if you are responsible as a provider for selecting your own level, I still recommend having this. You can have it in your one in each room, in each patient room that you work in. And again, if it's got this laminated sheet over it, it's going to be a little bit safe from spills and grime and whatnot. But also, if you have a handy dandy dry erase, you can actually write on that laminated sheet. So you can mark what you're thinking as you go through. Had it upside down there. You can mark what you're thinking as you go through. And then at the end, you can figure out where you are with it. So I highly recommend doing that. And then again, let me just share this again, since we added this section over here with these codes, if you do a different type of E&M coding, let's suppose that you're doing rounds in the hospital and you're a provider and you're like, well, I want this for the hospital setting. You could just get those codes put in here for the hospital as well. And if that's something that you guys recommend or request from us, we can do that too. I actually have them because I do them for different. The one that I have in my hand is actually for hospital services. And I even put in time. So there's not many providers out there that document or code based fully on time. There are some, but most are terrified to do that, which I really want to do another T-Talk at some point regarding time, because many providers feel like it's like the worst thing in the world, but it really truly can be a great benefit for you and can be a lot easier than having to level these services out. But it really depends on your specialty too. So for tonight, we are again going to focus on this first element now. So number and complexity of problems addressed. And I mentioned before that you have to read the fine print. So when you're going to select a level of E&M, so your office visit level, you are going to go based on 2 out of these 3 elements. So the 3 elements are number and complexity of problems addressed, amount and or complexity of data to be reviewed and analyzed, and then risk of complications and or morbidity or mortality of patient management. So we're going to focus on number and complexity of problems addressed. So when I talk about the level here, we're just referring to this one element. We're not referring tonight to the overall visit level, but we're going to use the same examples that I have from tonight. So the case examples, we're going to carry those across multiple days. And again, if you guys have a request for a specific note to be reviewed, you can send that into T-Talk. Just make sure you take out any protected health information out of there. And you can send it over or contact me if you don't know how to do that. Contact us through T-Talk and we'll get together with you and set up something secured and get some BAA signed or whatever we need to do. So let's go ahead and jump in. So for number and complexity of problems addressed, the biggest thing is having that chart in front of you. And then in addition to that, knowing what the guidelines say. So the guidelines, that 42-page document that we mentioned before, they break down each element. So I'm going to refer back and forth. If you have these in front of you, that's excellent. If not, no big deal. You can rewatch this as many times as you like. So for that first element, there's a few things that I like to start off with. So the element is number and complexity of problems addressed. So really the first thing you have to know is like what is a problem and what's considered a problem in the documentation, and then what is addressed. So literally these guidelines break that out for you. So down here, they actually give you the definition of problem. So a problem is a disease, condition, illness, injury, symptom, sign, finding, complaint, or other matter addressed at the encounter, with or without a diagnosis being established at the time of the encounter. So in other words, it could be a sign or symptom. Doesn't necessarily mean that there's a final diagnosis yet. And then they talk about, again, addressed, because it's number and complexity of problems addressed. So we know what a problem is now. And so what does addressed mean? So to not flip back and forth 1,000 times, basically addressed is if that problem is evaluated or treated at that encounter. So during that visit, there needs to be documentation supporting that that problem was either evaluated or treated, again, at that time. Can't be something from a problem list. That doesn't count because problem list is just a running list of problems. So it's historical information. It doesn't mean that it impacted that specific visit. So there has to be some kind of impact. That problem has to have impacted that visit for the provider. So once you know what a problem is and if it's addressed or not, then you're going to say, okay, how many are there? So that's the number of them, right? And then what's the complexity of that problem? And that's really where it all boils down to, is what is the complexity of what the provider reviewed from a problem perspective for this patient during the encounter. So this is where I'm going to go ahead and pull up an example. And so in this first case, I do have an HPI. This is a full note here, but the heart and soul of leveling ends up being in the assessment and plan, because that's where you're going to see the problems and how they were addressed or treated. But having an idea of what's going on with the patient is super helpful. And a lot of times you can get that from the history of present illness. And also it helps when you're auditing to be able to give some feedback to providers. So we will talk about this history of present illness before our evaluation and management sessions are over here. But I'm going to go ahead and drop down to the assessments because, believe it or not, we are already 20 minutes into this T-Talk. So this assessment shows diabetes type 2, and they have a little code here in parentheses. It says patient plan, continue using your medications as prescribed. Bring your CGM reader with us the next time you come so we can try to get this working for you, as I think it will help. Then there's some plan orders here. There's an A1C order that's going to show them their, sugar over a longer period of time and how stable that is. So there's several labs ordered here. And then it looks like they added a Dexcom G7 receiver. So this is a pretty basic, straightforward, standard assessment and plan. And I actually really don't like this assessment and plan. And we'll talk about why. So when I go over and perform audits like this, so for the providers on, I always like to make sure that I give the knowledge of really something called DSP, diagnosis, status, and plan. When we talk about complexity, the way that the chart is broken down that we'll look at, so the leveling sheet, it really is reliant on the status of those problems, what's going on with the patient, and showing that complexity in the documentation is absolutely needed. And so this example is good because it kind of shows you where documentation improvement really has an impact. They basically just say diabetes. They don't really tell us how the patient's doing. They don't give us a status there. Like, is it stable? Is there some other kind of complication or problem? They just are telling us diabetes and continue your medications as prescribed. Not very helpful with us trying to figure out where that would go. So if we just took that information at face value and we took a look at our chart here, I'm going to try to make this a little bit bigger for that section so that everybody can see. Please let me know if you're having a hard time seeing. But for number and complexity of problems addressed, we see one problem in there, which is diabetes. So they have the one diagnosis. We do know that diabetes, just in general, that condition is a chronic condition. It's a known chronic illness. So it's inherently chronic. We don't necessarily need them to say anything about the chronicity because we know that that's a chronic condition. However, again, we don't have any more details about it. So if we look under number and complexity of problems addressed, we would have to decide what category does it fit under? Does it fit under minimal? Does it fit under low? Does it fit under moderate? Or does it fit under high? And again, as usual, in that 42-page document that I'm not going to make you go through, they break down minimal, stable chronic illness, acute uncomplicated. So they break down a lot of the definitions that you will see on this grid here. But if we did all that in T-Talk, this would be a 5-hour T-Talk. And I don't think we're all prepared for that tonight. So with that piece of documentation, we know that that's a chronic illness and we don't have a real status. So if we just took that assessment at face value, we would have one stable chronic illness. That's where we would be because we don't have anything to the contrary. So We know it's not a self-limited or minor problem because it is a chronic illness, so it fits down here. They're not giving us, again, really the status, but we know it at least fits there. If we go down to moderate, that would be a chronic illness with exacerbation, progression, or side effects of treatment. We don't know that. There's no other details there. Then for it to be high, it would need to have a severe exacerbation, progression, or side effect of treatment. So in this instance, that's really where that would fit. Again, if you took that at face value, right? So that's just going straight to the assessment and plan and looking at what's there and then looking at our chart and taking it. And in many instances, if an audit is performed by a carrier, that could very well happen. That's why, again, when we're trying to help our providers, we want to make sure that they understand what to document, what really matters in that assessment and plan. Because you don't have to level out the history and examination anymore, more time should really be spent on shoring up that assessment and plan and making sure that the clinical picture is presented well in that assessment and plan. So when you have a condition, you want to make sure you document that condition to the highest level of specificity possible, with any exacerbation, any progression, any side effects documented, anything that maybe there's a comorbid condition now. Maybe this condition has caused another condition. So there's a lot of complications in diabetes. So you'd want to make sure that those are documented if they exist. And then that would actually add potentially some other problems that you may actually be addressing. So a lot of times, like whenever we work with our providers because we do offer revenue cycle management. So our providers that we offer revenue cycle management for, we typically like to do some one-on-one education as much as possible, or with their group as often as we possibly can. And we like to go over these rules with them, not because they have to do all of the coding. I'm a firm believer in, you really need a professional coder and professional billing staff because, clinicians, you go to school, you spend all that time to treat patients. So this is a whole nother profession. And I think that it's needed to have somebody review this and assist. However, you do need to understand these rules because these are things that are expected of you, and your documentation being the best that it can be will make sure that you are compensated appropriately for the work that you're doing. So if we actually took a deeper look at this note, let's go back up to the history of present illness really quick so I can, sorry to make you dizzy here. So we can see that this patient has a history of hypertension, bee sting allergy, type 2 diabetes. They have a lot of additional conditions here. Presents for an ear check and due to neuropathy. So neuropathy is something that is oftentimes found in diabetes, and it's a complication typically of diabetes. So that's interesting that there was no connection made in the assessment. So we also see here the A1C is 8.4, which is high. As coders, we are not allowed to interpret any kind of reading. So for the providers on the line, we can't say, oh, this person's A1C is, 8 or 12 or whatever. So we're just going to we're going to change the code to match that complexity. We are not able to do that. Your documentation has to be specific as to what's going on. So if there's any complication with that diabetes, it has to be documented. We are not allowed to make those clinical decisions, even if we know, even if it's obvious, we are not allowed to make that. Nor is an auditor that's reviewing the note. They're not allowed to make that leap. You have to document that. So if this is diabetes with hyperglycemia, you'd have to document that. So the patient says they've gained weight and the readings are all high. They're doing 16 units of Lantus and started the Victoza. So there is definitely some issues, additional things going on here. This doesn't seem like it's stable. He reports he had high numbers like 220, 140, and 190. Got it lowered down a couple times, commenting that he needs to pay more attention to it. Also went to an appointment with vascular surgery. But some reason something was canceled here. But it looks like he has some atherosclerosis in the legs. Again, I mean, is there something connected? Is this another issue? Seems like this may have been addressed during this visit. They're at least talking about it here, but nothing was pulled down into the assessment. So not really sure. He comments that he still has pain in his feet and that the pain started around when he was diagnosed with diabetes. So again, usually that's that neuropathy that is found in diabetes. So let's just talk about that for a second. So that would mean that if that neuropathy really has to do with the diabetes, that documentation would actually change that picture in the assessment and plan. If that were documented fully, it would most likely change the way that we looked at the number and complexity of problems addressed. It doesn't appear that this is very stable patients. So if this diabetes is progressing or, not improving or not doing as well as expected, we would be able to change that complexity to a higher level. So if we took a look back at the leveling sheet here, if that condition were documented, that there was some kind of progression or side effect, or that it was in exacerbation, that would move us up to moderate, because we would have a chronic illness with exacerbation, progression, or side effect of treatment. So pretty interesting that, again, just the way that the provider documents and explains in that assessment and plan has a huge impact on where we go with it. We can't make any assumptions or jump to any conclusions just based on what we've read in the history of present illness. Sometimes too, we have to watch out because some of that information can be copied and pasted over from prior visits. So that's another reason we don't always, know for sure. We have to make sure that our providers are carrying that down. So we want to make sure we get a diagnosis, we get a status, and we get a plan of care. Additionally, interesting that they chose to just state, continue with medications as prescribed. I'm not really sure that that was the only bit of conversation that occurred during that visit. So many times, again, providers don't really know, okay, what should I be including in my assessment and plan? Like what's important for me to explain? So it looks like I've got some comments coming in here. So Aline, I see you did something about minimal and then low. I'm not sure what your question was there. If you want to type that out again, I'm sorry, I don't know what you were asking there. And then let's see, we've got something from Lindsay. Oh yeah, it looks like two different patients based on the HPI versus assessment and plan. That is absolutely true. And when I saw this one, I was like, oh, this is perfect to use as an example, because our providers too can kind of see how that flows. And I don't know if you guys caught it, but there's something else that I want to show you with this note. Here it says it's a 63-year-old woman. Then they say saw him, and then he. So it's kind of going back and forth, and this note just all around kind of appeared to be a mess. And we also see that happen sometimes when providers signs too quickly on the same day. I mean, I know, trust me, I get it. Like, we want to be able to sign off and close them out and get that done like as quickly and as soon as possible. But it does pay off to take a look at what you've got in there and then flow all the way down to that assessment and plan and make sure that you've captured every problem that impacted your care during that visit. So it looks like some additional work may have been done in regard to the atherosclerosis in their legs and vascular surgery and the neuropathy, and probably some more education given on the diabetes and managing those sugar levels. So really documenting that in the assessment and plan is going to help out, because if we take a look back again at our leveling sheet, our number and complexity of problems would have gone from a level 3 to a level 4 visit. Then the difference between a 4 and a 5 would be if there was some kind of severe exacerbation. So many times providers will say, well, what do I need to state there? Honestly, you just need to state the severity. If the exacerbation that patient is experiencing is severe, state that it's severe. That's perfectly okay. It's helpful. It allows us to know for sure that where that should fall. If it's not specified as severe, then usually it's going to be assumed as a lesser, right? That it's just an exacerbation, unless it's very, very obvious that it's severe, that they're needing to go get care at the hospital or something like that, unless it's very, very obvious that it's severe. But I'm all for providers actually stating the severity. So that status would be, again, that severity. So your diagnosis, the status, and plan of care. Then we've got another example here that I wanted to share with you guys. So let's take a look at another one that's a little bit different. Yeah. I like that little emoji, Ricky. Thank you for that. That's pretty funny. Mind blown. I know exactly, right? So let's see if we can take a look at another one here. So this case, this patient looks like they originally came in for a yearly, but they've got, let's see, heart failure. They're on some medications there. History of multiple personality disorder that resolved once he stopped talking to himself. Notes he did not have memory gaps with separate personalities. That's interesting. We've got a physical exam. So here under the assessment, they have it numbered, which is nice. I think we always appreciate that separation. Helps us kind of know the process here. So for number 1, it's heart failure with reduced ejection fraction due to cardiomyopathy. It looks like he's not been taking one of his medications, thinking that someone had discontinued it. They checked the records and they actually wanted them to continue, and they're renewing the prescription. So they're going to decrease a medication, continue a medication, restart a medication, continue follow-up. Let's see. And then number 2, cardiomyopathy. And there's some labs ordered. And orders not associated to today's assessments. I do not like when we have a section like that. So let's talk about that for a second. So orders not associated to today's assessments. Sometimes I see that in the electronic medical records, and it sometimes has to do with orders being put in after the fact, but it's not always that they're not related. So for the providers, please be very careful of that, because you want to make sure that you're going to get credit for whatever order you put in that does have to do with that assessment. If it doesn't have to do with that assessment, there's rules around that. So within the rules, that 42-page guidelines guideline document, they talk about, if you, for example, if you just notate that a condition is being followed by another provider, they don't allow us to consider that when selecting your level. So that does not add to complexity. If you provide a referral without evaluation, so it'd be similar to just popping in orders that is not related to that evaluation, that's not going to credit your visit. So be very careful with the way that the note is structured and what's going into those orders, and be sure that those orders really don't have anything to do with what you've assessed during that visit. Otherwise, you're not going to get credit for it. So in that example, we did have, at least a little bit more there. We had two conditions, and there are some issues with medications. So, um, you guys take a second. Let me add the screen here again. And let's see let's have you guys vote for that one. Where do you guys think that one would place us at on the number and complexity of problems addressed? I'm just interested to see what you guys vote on, whether that's minimal, low, moderate, or high for the number and complexity of problems addressed. So again, we have heart failure with reduced ejection fraction due to cardiomyopathy, and we have cardiomyopathy unspecified. So what do you guys think? Where do you think that would go? And let's see who pops in here. Who's got the guts to pop in? Ah, okay. We've got somebody saying hi. Okay. Interesting. We've got a low. And I see a couple people. I'm interested to see what you guys have to say. Lindsay, moderate. Lindsay, moderate. Okay. Moderate. Another moderate here. I think I would jump on I think it really represents a moderate. I would jump on the moderate bandwagon. Michelle, moderate. Yep, looks like the overwhelming vote is going for moderate here. Yeah, they really didn't have much of a plan for the cardiomyopathy. They did order some labs, but there wasn't really a lot of specificity in there where they were going over the actual status. So again, the pattern here is a lot of providers, and a lot of them just miss giving us that status. The prior guidelines, if you guys remember, they really didn't. It really depended on if the problem was new or not, and then how many problems there were. So this is a newer concept to the providers. So I think that's important as well as we're talking through and giving that advice to the providers, making sure that you understand the new way of these guidelines, and that it really is important for you to give us that specific status. It really makes all the difference. And you can see it too, because some organizations have a setup where the provider will go in, they'll see the patient, they'll select the level that they think the visit is, and then a coder goes back in and reviews, and you can see a difference between what level the coder selected, what level the provider selected. And then, we get some audits and some also requests for education and reviews just because of that, because you'll have providers saying, hey, we don't agree with what the coders are choosing. Then the coders are saying, hey, we're using these guidelines. And it typically boils down to just a documentation improvement opportunity, usually. Sometimes, there's some education that could be needed on both sides, or either side. But usually it boils down to, again, providers just kind of not knowing, because in your head, like if you know what you want to say in your mind, what happened, how difficult or complex the patient was and caring for that patient was during that visit. So it's not that you didn't necessarily perform that complexity, but is it showing in the documentation? So have you explained that story well enough and documented it well enough inside that assessment and plan for us to see it from the outside? And I am always on the side of, hey, I want to make sure that the documentation speaks for itself, so that when you go to sleep at night, you don't have to worry about if you're audited or if or and when you're audited by an outside entity, that you can just sleep easy by knowing that, hey, my documentation is good. It's pretty audit proof, that you're not going to have to worry about whether you're going to meet that mark or not. So getting your documentation improved and really showing that level of care through that assessment and plan is just going to help you tremendously. And it eliminates that argument. So again, when you're documenting a chronic illness and there's some kind of progression or exacerbation or side effect, stating the severity of that exacerbation, progression, or side effect is so incredibly helpful, because we may not see it through that documentation unless you state it, or again, unless it's completely, utterly obvious. We may not know that. So that, again, is just super important. The other pieces that are important here, let me just kind of pull this back up. Depending on your specialty, you may have more of a pattern of a mix or higher level. So some specialties tend to just have higher complexity in this area. So for example, cardiology is a big one, that typically those patients come in and they have several chronic conditions. So they may just automatically dump into this moderate category often, because they just may have 2 or more even stable chronic illnesses. Where in the primary care setting, it could be 3s and 4s mostly. Pediatrics, you're going to be all over the map, because pediatrics, you see everything, right? Everything. It could even be a worried well in pediatrics. So it could be a minor problem. It could be, something that the patient didn't necessarily need to come in for. So the parent could be just concerned. So the red here, again, I mentioned this before, just to kind of recap in case you guys are wondering, these were updated and they were added to the table in 2023. That's the red text. They did add a stable acute illness in this section, which I think was helpful. And they added, and there's a difference here between one acute complicated injury. So we get a lot of questions about complicated injury. So I don't know if you guys have any good examples of complicated injury. I have my standard one that I use a lot, but I'm curious to see if anybody has any good examples. Let me see. I got a comment here. So Aline, I'm sure the physician gets upset when they haven't explained the assessment plan correctly. Yeah, it does happen. It does happen. But that's why, again, with the changes in these guidelines, it's super important that we work with our providers to get them on track, because these guidelines are so drastically different. And I honestly think they're really beneficial. We don't have to focus so much on, pinpointing certain things or meeting certain check boxes for history and exam. You can really get to the meat of it. And I think that a lot of providers are starting to appreciate that as well, especially specialist providers, where there's a lot of coordination of care and sharing of documentation going on. Because again, it used to be that these notes would just become so huge and full of stuff that didn't make a difference to another provider. I mean, I remember working with some and they would just get irritated getting some of the notes sent over, because they're like, where is what I need to know? And 99% of the time they would just go right to that assessment and plan anyhow, because they knew that's at least where they were going to find the most helpful information for them. And it makes sense. It does make sense in that way. But the history and exam should be commensurate with the situation at hand and should flow through the note. So it should all make sense together and tell a good story. So for that complicated injury, which falls under moderate, so acute complicated injury, the easy example that I always give to providers is a fall. So one patient could have a fall and it could be an acute, uncomplicated injury. Maybe I have like a simple sprain, or I could fall and I could smack my head, and I need maybe I've hit my head, I've injured my wrist, I've injured my ribs, whatever. But you may have to do then a neurological exam. You may have to order like a CT of the head to make sure that that's okay, that there's no concussion. So that's where it gets a little bit more complicated, right? So is it a uncomplicated injury, or is it something a little bit more complex, a little bit more complicated? So again, it all comes down to that documentation and how we're describing it. Another common question that's also oftentimes misused is this one. It's one undiagnosed new problem with uncertain prognosis. So to go over that one without getting too crazy into it, that would need, because you could say that any condition, any sign or symptom that you document, you don't know, it is an uncertain prognosis, right? Like if you haven't made a final diagnosis, then it is uncertain. You don't know. But that's not what this section is for. And they do explicitly state that in those guidelines. That section is related to a condition that could pose a high risk of morbidity or mortality. So the example that has been classic that they've used is like a lump in the breast that could be cancerous. That, again, if they have cancer, that would be something that would be of higher risk, right? So it definitely would increase the risk of morbidity and mortality. So it has to be something that meets that level. It can't be something that's just like, well, I don't know if they have flu A or a regular cold. Like that's not what that section is for. So hopefully that makes sense to you. And let's see, what else do we have here? So many times too, we get the request of, can you just tell me what's a level 5? Like what just meets a level 5? That is super difficult because you just need to follow the elements here. And again, it takes 2 out of 3 of these elements. It's not any one thing that would allow that level to be, a 2, a 3, a 4, or 5, right? So it's 2 out of 3 elements that meet that criteria. So it could be true that you may have a patient that you're documenting on, and maybe they have that chronic condition with severe exacerbation, right? Maybe they do. But just because this element meets that level of high doesn't mean that it's a 5, right? You need to then level out the other 2 elements in order to make that decision. So it depends on, again, that complexity of the assessment, the plan of care, and what all goes on during the visit. So data that you've reviewed, work that you've put into that assessment. Even if the patient has an acute or chronic illness that poses a threat to life or bodily function, again, you may meet this element here, but that doesn't automatically make that entire visit a 5. So there's multiple things that would need to meet the criteria to get to that level. So Lindsay, I'm not sure what is so funny, but I'm assuming that it's the question of the level 5. I'm thinking maybe you've had that asked a time or two, because I know that and it's a tough one because it's like a picture's worth 1,000 words, and I think that examples are fantastic. And I talked about this last time. Like if you're going to provide education, even if I'm asked to provide education to a group, for evaluation and management like this, but they don't want an audit, I still say, I need you to send me some notes. I don't, it doesn't have to be an audit, but I need some notes to use as examples. So I want to use your examples to walk through them because everybody documents differently. So even within a practice, like, the providers that our team does regular work for, oh my gosh, it's so different from one to another to another. So the recommendations for improvement are naturally going to be different. And what one provider may need to work on documenting, or maybe what they could scale back on, is not going to be the same as another. So it's super important to have those examples to be able to then use them to create that education. I am not one for cookie cutter education at all. That's why I always encourage you guys to send your examples in if you have questions, because that's really the way to help. And the providers have the right idea. So when you guys are asking, well, tell me like what's a 5? I totally get it, but I like to say, you show me what you think a 5 is. So you give me a note where you think it was a 5, and not necessarily because of the documentation, but let's talk about this. So why was the care that you provided to that patient a 5? Explain that to me, and then I can help you understand what might be missing. It's either that you're missing or you're misunderstanding the way the guidelines are, or you may be missing something from your documentation. So again, it's not always that somebody's trying to pull one over and always do 5s or always this. Sometimes it's just a matter of understanding how this works and how to explain the story. So we all, have our strengths and our weaknesses, and I think it's important to see that. So I always request for some notes to be sent over so that I can take a look and use those in the actual development of the education. Otherwise, I think it's sort of a little bit of a disservice. So, yeah. Oh, okay, Lindsay. Yeah, the providers all want 5. Well, I mean, who wouldn't? I don't know if you guys see the, I would pull it up here, probably slow everything down. But the price difference on these is incredible. And they did change, like the fee schedule has gone up too over the years with those E&Ms, trying to make that back up for the providers in primary care. And yeah, exactly, they a lot of them do, and they want to give limited and hey, who could blame them? I think once they start realizing like what the what's actually required, I mean, if we're all honest, right, it doesn't really take a lot. It doesn't really take a lot of documentation to get there. It's just the quality of it and knowing what needs to be there to understand exactly what that level is. And the way that they changed these guidelines, if we take a look at this overall, I'm going to make it a little bit smaller. It's super hard to, to cheat this. It's not the same. So before, when it was like a checkbox system, it may have been easier to just say, oh, okay, well, I can just document this in my history, document this in my exam, and then I need to make sure I've got at least 4 problems in here and a prescription, and then I'm going to make it, this level. It was a lot easier for those that wanted to try to game the system. It definitely was a lot easier then than it is now. So they've definitely made this more geared toward quality of care and complexity of care, right? So and those are the 2 things that they've been preaching about now for years. They're really wanting to focus on quality, and this is what they're doing. This is what they're pushing. But the more our providers understand how this works, the better off we can be. We also, we need to be able to keep the doors open too, and they deserve to be compensated for the complexity of care that they're providing also. And it does range too, again, based on specialty. Exactly, Aline. So it doesn't need to be lengthy to tell the story. And that's true. It doesn't. It does not need to be. And some things don't matter in the story. And I know that sounds awful, but I know that there was one provider, and he used to just have to review his notes all the time. But he used to write this huge story up about, it it was interesting. Don't get me wrong. I felt like I was reading a novel, but just about just like so many things in the patient's history about wars that they were in and different things that they went through. And the specialty was not psychiatry. So it was just interesting, but it didn't help. It didn't help the provider. I mean, it was an interesting story. I certainly didn't mind reading it, but it didn't help the provider when it came to the level of care. That's all. So, interestingly. So I think that's just going to wrap it up for the number and complexity of problems addressed for the night. Let me know if you guys have any additional questions. Just place them in the chat. I just want to remind you guys, I know a couple people have joined since, but if you have specific questions, topic ideas, concerns, you want to send us something, contact us at ttalk@stalkinghorseLLC.com. So that email is specifically for this channel and for T-Talk. Don't forget to join the herd. So like and subscribe to the channel. Also, if you like these topics or a specific video in general, if you hit the thumbs up in YouTube next to that video, that's greatly appreciated. That upvotes the video. So then it will let others know to take a look at that one. So that's also appreciated so that you can kind of share the word there. And if you want some more information, you can visit stalkinghorseLLC.com. We have some webinars up there. And also I can go ahead and post the this leveling worksheet and the guidelines up there for you guys to take a look at. So if you go to stalkinghorseLLC.com, you can look under T-Talk and you'll be able to find these. You can also look under our products page for different webinars that we have there. So thank you guys so much for joining. It looks like I've got a couple more comments here. Let me take this down. I always forget those banners up there. Oh, thank you. Thank you guys. Appreciate it. You guys are really sweet. I appreciate you guys all joining. Thanks, Michelle. Appreciate it. I hope to see you next week again. And so you guys reach out if you need anything, if you want to hear anything different. I will see you guys next Tuesday. So again, thank you. Have a good night.